Okay. Just something about the case.
Sir, just to introduce our surgeon, Dr. Rajendra Prasad, he is innovator of terminal chop, sewing needle microcapsulotomy, terminal the wedge tool, hydrodissect for PPC. He has many awards, National Innovator Award 2018, ACRS Best Video, consecutive 2022 two awards. So he has received gold medals almost every conference. Now, Dr. Darshika will tell about the history of the patient.
So today we have a 65-year-old female housewife by occupation, resident of Dehradun only. She presented with diminution of both eyes, but more more in the left eye since past 1 year. The grading of her cataract is in right eye, it is grade 3 cataract, but in left eye she has intumescent mature cataract, and her left eye vision was hand movement close to face. The B scan we did, it was within normal limits, and she has an astigmatism of 0.75 at 3 degrees in her left eye. So the ILPAR is plus 26 at minus 0.05 myope, and we are using Hoya Vivinex monofocal lens for her today. And the patient is very lucky to get operated by sir. So I'll hand over the video to sir.
Okay. Hello. Can you hear me, Dr. Vinod?
Yeah, very well.
My voice is okay?
Yeah, clear.
All right. Good morning, everyone over there. And I thank you, UKSOS, for inviting me here to operate this case. And I'm here in Doon Hospital. Dr. Oja has been very kind to keep my surgery here in this hospital because I have some association with Doon Hospital. I did my internship here in Doon Hospital in 1980. So this is my hometown, and really very happy to be here. So I'm taking up this case. Already doctor has explained about the case. Seems to be a intumescent mature cataract. And so I'll be starting the surgery. This is my side port. Mataji, seedhe dekhna, Shabas. Blue Rex. So I'll be staining it with the Blue Rex 0.06%. And I'll inject some air first, and then Blue Rex. Saline. So I've given one incision to start with. So I'll be evacuating the fluid now. Patient has a little deep set eye. So you could see the accumulation of the fluid. Give me a swab stick. She's moving her. Okay, it's fine now, centered.
Yes, very well.
So this accumulation of the fluid is there. Give me one cotton bud. Look, cotton, what you can say. Just roll out the cotton.
So this Blue Rex stains your incision also. So it helps to identify. Sometimes you can't see where the side ports are there.
Okay.
So that's one of the additional advantage of staining.
So there is some accumulation of the fluid. So I'm putting one cotton bud here. So
In cases of deep set eye, you can put you can put a gauge piece there near the
so I'll
lateral
put this,
canthus,
cotton bed. Give me
so that all the fluid is drained from through that to the bag.
So I'm using methyl cellulose only because this is what I prefer in this kind of cases, because I want the extension of the anterior chamber along with the comfort of having it removed and expansion of the anterior chamber. Bas Mataji, bas light dekho seedhe. Hilana nahi. Give me main side port again and main port then.
Some people use side port and some people use MVR blade for that. Have you used both of them, and what do you feel?
Yeah, I use both, but I think they have given me the side port. This is the knife, because with this, actually, the only problem is you cannot judge the size of the the incision actually. Now this is 2.8 millimeter, no? 2.8.
Can you
I'm making the main part now.
Can you center it? Yeah, a little, yeah. We are not seeing the upper part,
Is it
superior
okay
part.
now? Okay.
Yes, yes, now it's better.
So I'm taking it on the top. I'm sitting on the top. So this patient has almost equal K reading. So my preference is to operate from the top. So I'll be making a 3-planar incision.
You see how the
This is
triplanar
the
incision is being made.
First groove, then enter through the stroma, and then penetrate. So this is the 3-plane incision. So 3-plane incision works like a valve. Give me more fluid. Sorry.
Just one clarification.
Yes.
In case of deep set eyes, and if the
Yeah.
K readings permit,
Yeah.
will a temporal approach not have been better?
So I'm happy with the top actually, because I normally sit on the top only. I operate all the position from the top only. Even
that's-
temporal I do from the top.
Okay, so,
Any temporal I do from the top only.
so that's a personal
I can
choice.
use my left and right hand both. Give me axis. No, give me puncture. Puncture. So this is called as a saving needle microcapsulotome. So as you can see, this has a round tip, pointed and sharp pointed tip. So I'll be puncturing the anterior capsule with this first. This actually just wait. You give me, this is not holding actually the lid. Give me the speculum, wire speculum. Give me the wire speculum.
This swing needle is just like the needle you see in the swing machine. There is a no hole, and this is not cutting like you see in our disposable syringe. This is a centrally pointed one.
सर जहाँ छोड़ा वहीं रखो. सर नहीं घुमाना बिल्कुल भी अब.
Basically, if you are using a disposable syringe that has side cutting, so that can extend. But this is a circular needle. Normally we use in swing machines, or you can have seen at home. This is the same machine needle is using.
So actually because of
It's
the
available with
that,
epsilon, or you can make it your own.
not
also.
holding, so I'm putting the wire speculum.
Again, in deep set eyes, I think one modification could have been, instead of doing a lateral canthotomy, you could have just done a crushing of the lateral canthus.
No, I have not done any canthotomy. Look at the light. I have
that-
not
that
done any
helps.
canthotomy. I have just done the
Yeah,
stripping
No,
of
but
the
especially for the beginners, I think that,
now it's
because,
fine. Yeah, give me
yeah.
this go again. This go.
that avoids pooling. So just crush, you don't have to cut it, actually.
See, actually, that is very painful to the patient. So normally, if you can avoid that, is always better. Don't do all this.
I think it's too troublesome. Then you can crush it
Yeah,
and
if
then
you
cut
have
it.
too much of
But hardly it
too
is
much
required
of deep
nowadays.
set, then only that should be done. Ideally, it's very painful to the patient. Mataji, light dekho. So I'm going to puncture the anterior capsule, although it's not very visible. Actually, this cornea is not very clear.
It's a 2D. It's a 2D. You wouldn't see any difference. It's a 2D. It's from Doon Hospital here. Yes, yes.
So you can see the.
Like
to see the needle. Because of the pressure.
Look at the needle. Very important. This is a bent swing needle.
Visco hi dena. See, actually, the cornea is not so clear, and the pressure seems to be very high.
So basically, that makes a
I'm
smooth central
trying to-
puncture
I'm
without going sideways. That is the advantage of this needle. And Dr. Rajendra Prasad has mentioned earlier also that you can make multiple incision also. Then you can join them. Or you can make a one needle, one central incision that takes care of the intumescent cataract. Dr. Rajendra Prasad, can you show the needle under the microscope?
I'll show you later. I'll
So
just
can you
complete
focus on
the
that needle
practice
here?
now first.
Okay, just you let you finish your surgery, then show us. So he can make a very small
Very-
central opening. So chances of running of rexes are minimized by this technique. So there are many ways to do white cataract or 80% cataract.
चलाओ जी माता जी इसको.
In the earlier
Actually,
surgery,
the
by
deep
Dr.
set, it's so difficult to put the Raxis forceps also.
Yes, it's a deep seated eye. And putting visco in between is very, very important once you're doing the rexes, especially like eyes these.
At least in my hospital, bubble in visco is a trouble. So all my staff, they know that no bubble in the visco.
Give me more.
Bubble is trouble.
Yeah, bubble will impair your view. So this is what happens actually if you have too many bubbles. You have to remove the bubbles before getting it.
Is it a HPMC you're using?
HPMC. I'm using HPMC only. For this.
एक चीज बताओ, हम लोग जैसे बोलते हैं कि हमारा जो पॉलिटिकल है उसके अंदर एनर्जी डिस्ट्रीब्यूशन इज 100%. आप पूरा कंप्लीट करो है ना. उसके अंदर नियर का 40, पार का 40,
Hydro.
एपोडाइज.
I made a little smaller Rexis to start with.
So the rexes has been widened. Can you little center it? We are not seeing the superior part.
Patient is moving. Mata ji, sir nahi hilao. Sir hilao nahi bilkul bhi. It's okay now, centered?
Little more.
इसके अंदर एनर्जी लॉस होगा ही होगा मल्टीफोकल के अंदर.
Now it's fine?
Yeah, it's better now. Centered.
देखो हमने एक आता है कि एक बार सर्च होगा सबसे हम लोग पूछ लेंगे. It is 100%. It is not no multifocal can give you 100%. अब सोना में बनाएगा क्या? डेमो मात्र लाऊंगा कोई जाऊंगा. चलिए डेमो देखो बाद में बात. अभी तो हाथ पे देखो क्या.
There's a lot of disturbance of the audio, please.
I'm just trying to evacuate more fluid from the capsular bag.
So he's trying to remove as much as cortex possible.
माता जी टूडी नहीं उठाओ, जहां रखा है वहीं रखो. बार बार टूडी उठा देते हो आप. ऐसे ही रखो. So you can remove with the visco also, you can evacuate the fluid out of the cavity. Actually, accumulation of the fluid is hampering my view actually. So this is the, but still fine. So I just made the nucleus free. What I'll do is I'll complete the phaco first and then extend the pupil, Rexis. Now this.
You see, it's a deep-seated eye. There's a lot of pooling of fluid. So it causes almost say, this is a submarine cataract, you can say. And patient is not very cooperative, so make the things much tough. क्या है?
We welcome Dr. Kudlu from Mangalore. Dr. Rajendra,
Yes.
they have given you intentionally this type of case, heart cataract with the small eye.
Yeah. Small eye, deep
Because
set.
they want to see you are going to handle such complicated case.
No problem. Okay. Give me chop. 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 चॉप है ना? नहीं नहीं चॉप दे दो, मैंने उनको कह रहा हूँ सेटिंग. Oh, this actually, she's moving head so much. माता जी थोड़ा ठुड्डी जहाँ रखता हूँ ना मैं वहीं छोड़ो. फोकस नहीं हो रहा. Why is not focusing? I don't know. फोकस यही है ना. cannot focus here. Yes. तो ये माइक्रोस्कोप क्यों नहीं मूव कर रहा? फोकस नहीं आ रहा. कहाँ है इसका? मैक्सिमम पे है क्या? Okay, no problem. I'll just pick up again. What's not focusing? नहीं हो रहा. Microscope is not moving. Why? इसको दे दो थोड़ा सा मुझे.
Excuse me.
इसको. माता जी सर एक जगह पे रखो बस 2 सेकंड और. My God. Taking her right, up, down, I know.
Are you using your terminal chopper?
I'm using, but I don't know this.
I think this is a
sleeve
tough
is
case.
getting folded.
Getting deep in here.
Sleeve में fold हो रहा है. Sleeve ठीक करो इसको.
Maybe incision has to be increased a little bit.
No, the incision is fine actually. This
Okay.
sleeve भी आगे से fold हो रखा है sister.
So it's one of the toughest case you can see.
My God.
Patient not cooperative,
कोई दूसरा sleeve
fixated
लगा.
eye, hypermature cataract. So we have chosen the best surgeon.
More sleeve. ये
That's
दोबारा
why we have
Dr.
chosen the
Sushil?
best surgeon.
खोल के दोबारा लगा दो. ऐसे ठीक
Hello,
करवा
Dr. Sushil, we
Such
have
cases,
Oculon. You
when
can
we have
provide the
problem
Oculon
with
to
such
sir. Dr. Sushil, can you hear me? We have the Oculon in our OT. You can give to, no? Patient
we
will be
have
more
problem-
comfortable with that.
When we have problem in such cases, when the cataract is hard and eye small, patient not cooperative, we should not hesitate to give the retrobubble injection or subtenon injection. Even at this stage, you can give the retrobubble,
इसको.
peribubble, or you can give the subtenon injection. So we should not. Yeah,
So
intracamera you can use.
Anesthesia is
Yeah.
not a problem at all. It's only the
Good morning, madam.
phaco tip which is
Yeah.
Steve-
No, we are talking
Steve
just for
rolled
the,
up, actually.
we are talking about just the learners, because it's beginners. So if there is any issue in their tackling in the topical, you should not hesitate to do for the
Yeah.
intracameral subtenon. Subtenon is very good anesthesia.
Give me chop. So I'm
So he's
using
going
this,
to do terminal chop. He's a terminal chop.
This is a chopper, special chopper. So what I need to do is
RP, Dr. Kudlu here.
I don't-
I could able to see your terminal chopper.
Yes, Dr. Kudlu.
I use your chopper always because
So-
the most safest chopper, I believe. The chances
from
of
the
rent
center
is almost
And,
next to zero.
Just hook it from the back and you crack the nucleus. You can see the crack.
Yeah, excellent,
The
excellent
crack has
chopping.
gone Through and through. So this is the first crack I've done. Just, you can see the nucleus. Hopefully it's in two pieces. This is the complete two piece we have now. So I'll be taking the first heminuclei. Again, just hold it from the center, draw it a bit, hook it and crack it. You can see the second crack. So this is the second crack. So you have these free pieces. Now I'll just take the first free piece. This is over. I'll take the second piece, which is free here.
The Feroz, Atli.
Machine is Faroz by Artley.
So this chopper is a unique, it has a
So
bent
this
like a finger.
Machine is working very well. I'm first time using this machine. What I think is very good chamber control and very good hold, which normally I don't get with any other machine, I think, because this is very good machine. Working very well. See the sister, just put some saline on the cornea.
One drop.
Could you just elaborate on the settings you are using right now, doctor?
Setting is 450 vacuum. And so I'm doing the sub chop.
45 is the
450
flow rate
vacuum, 40 is the
and
fluidics.
power is 70.
power is, how much
70.
power you have given me?
Yes,
70 is too much.
70 is
I
the
just
power
need 40, 50 power.
in a
for this particular
in a
case.
linear mode.
So this chamber is very stable even at high
Very
vacuum.
stable chamber.
That
This
makes
is
the machine very good.
machine
Atli
is
machine is
complete
very
now.
good.
Thank you, Dr. Rajendra sir. Now we are shifting to our next case from the Drishti Eye Hospital. I would like to thank.
Can you show the chopper, Dr. Rajendra,
Ah,
please?
please,
Before we shift.
Dr. Rajendra sir is going to demonstrate his chopper, and also I will thank from Doon Hospital and
So as you
Uttara
can see the
Ophthalmic
chopper,
Society.
can you see the chopper now?
Also, your chopper and swing needle also, needle Dior.
Now
This chopper is very
actually,
unique.
As you can see, we call it as a triple edge cracking chopper. It's a wedge tool, and you see the tip is round and round tip. It's olive tip. So like when you are hooking the nucleus, it won't, even if it touches the posterior capsule, it's not going to disturb the posterior capsule at all. And it is triple edge means like you can crack the nucleus this way, or this way, anyway. So you don't have to use two choppers, right and left. The same chopper can do the things.
Good. And the needle.
Needle, I'll just show you the needle.
Thank you,
also.
sir. Now I request
So
audiovisual team to.
this is the needle. As you can see, the needle, the tip is like sieving needle. We have just bent the sieving needle tip. It's a round and pointed tip. So this gives you a puncture on the capsule and evacuation of the fluid. The initial pressure is released with this. And the moment the initial pressure is released, so you have a very less chances of extension of the capsule to the periphery in the form of Argentinian plaque sign.
Excellent surgery. There is the reason I think RP, we all call you Terminator.
Not the slime machine.
Lens
you.
will be Nanex, sponsored by Hoya. Now I will request audiovisual team to switch the transmission to Drishti Eye Hospital for next case.